Our first topic this afternoon is managing a safety and health incident, presented by Christopher Jankosky. Dr. Jankosky is a Senior Vice President of Medical Operations at Workforce, a national occupational health company. He's based in Carmel, California, and as a physician executive and a retired Navy captain and flight surgeon, Dr. Jankosky has extensive experience in cutting-edge science, direct patient care, academic medicine, data analysis, and epidemiology. He's board certified in neurology and occupational health and environmental medicine. Please welcome Dr. Jankosky.
All right, thank you, Steve. Everybody can hear me okay? So I've been talking to a bunch of people this morning during the conference, so I'm going to try to deviate from my slides a little bit, tell a few more stories, have something relevant for you. You guys really have the hard job, all of you guys out in the field doing real world stuff, so thank you for that. I'm going to just start by saying up front that the best thing you can do to really manage any incident is just to observe and to listen. During my educational training, I was trained by some really good neurologists along the way at really good institutions, and they would say they could diagnose like 99% of people with Alzheimer's, with Parkinson's, with multiple sclerosis, with seizures, with strokes, just by listening to them and just by observing. And that's actually pretty true. Once I finished my training, I found that's pretty true. MRI scans, EEGs, all those other tests, that's just for confirmation. Really, if you listen and you observe, you can really take care of people and understand it. And you guys are already doing that. I mean, how many of you guys are parents out there? You have kids at home. You know, so my son comes in and he says, "Hey, Dad, I was playing outside and I hit my head. My head hurts." I'm like, okay. Ask him a couple questions. You want to go back outside and play? Yeah, okay, go ahead. My daughter wakes up, stomach ache, not feeling well, like maybe she wants to vomit. It's like, okay, well, let me think about this. Should I let her go to school? Let her stay home? Should I call the doctor and ask some questions? Should I take her into the acute care? I mean, you guys deal with these decisions on a personal level as well as on a professional level. So these are the types of things you're doing every day. Let me see if the slides move forward. Anyways, I think this is my intro slide. You can sort of ignore this. But essentially, I've had a lot of experience. Is this a little bit too loud, by the way? It seems loud to me. Is it okay? So I'm going to share a story with you about like how difficult, maybe your decision is making medical decisions, but sometimes it's even hard for me. So when I was in the Pacific Submarine Force, every week, there would be some submarine out there which needed medical advice. And they would have to come through me. Even if another physician was answering the call, they had to call me on the phone, tell me what they were going to do, and I would give my approval. So I thought I was pretty good for handling emergencies. So I'm on a flight, American Airlines, going from Chicago to Los Angeles. And the stewardess says, "Is there a doctor on board who can help out a passenger?" So of course I stand up, and it's a full flight, a large jet, and there's a woman, a few seats back, and she's in her 50s and she's having chest pain. And the friend she's traveling with works, believe it or not, for the American Heart Association, and says, maybe she's having a heart attack. So I exchange seats with her friend, and I sit down next to her, and I start chatting with her, and the stewardess brings me this little emergency kit with a little stethoscope and blood pressure, and the stethoscope is like $3. It has those hard earpieces, those hard plastic things, and I'm trying to like push them really hard so I can hear. I guess I'm hearing her heartbeat, and I guess I got a blood pressure, but the airplanes are loud. So stewardess comes back and says, hey, can you give me an update? And I was like, it's right behind the breastbone. It's been going on for a couple hours since she had a big burrito in Chicago. And she says she's been wandering up and down the aisles, and it just won't go away. And it's like, now, for men, it's like left-sided chest pain radiating down the arm. But for elderly women, it's a little different. It's not the same. So this could be a heart attack. So I'm sitting down next to her, I'm chatting with her and reassuring her, and I tell the stewardess, I don't really think it's a heart attack, but it could be, but it sounds more like indigestion, gallbladder, esophageal reflux. So she says, okay. And then she comes back a little while later. Meanwhile, I've had a half an hour to observe this woman and talk to her and reassure her, and she seems to feel like, yeah, it's probably not a heart attack. But stewardess comes back, and she whispers to me, sort of quietly, okay, so the pilot has called down to McCarran International Airport in Las Vegas. And he is willing to land the plane. He has permission to land the plane in Las Vegas. It's about 6 minutes, we'll be on the ground. Or Los Angeles is about 35 minutes more. And we'll have EMTs meet us there as well. And I'm like, okay. And she says, the pilot talked to the American Airlines physician at like the American Airlines headquarters, and the American Airlines physician said, do whatever the physician on the plane wants to do. And I'm like, what? And she's like, well, it's your call. And I sort of looked at the passenger, and I said, no, we're going to LA. This is not a heart attack. By the way, how many of you guys, like, raise a hand, like, how many of you guys think that you would have said, go to LA, and how many of you guys think would have said, go to LA? And then how many think would have said, hey, just land in Las Vegas, you're not 100%? But part of me, subconsciously, is thinking, wow, this is an entire plane full of, like, 300 people. And do I really want, like, as soon as I get to Las Vegas, they're going to, like, wheel her out of the plane, and she's going to have, like, a huge belch. And she's going to say, oh, I'm fine. Anyways, as she's leaving, her friend from the American Heart Association, I give her my business card, and I'm like, hey, you know, if for some weird reason the ER wants to talk to me or whatever, and also I'd like to follow up, you know, have anything. So I don't hear anything for like 2 to 3 weeks, and I'm like, oh my God, she must be dead, you know. And I'm really anxious, like these are hard decisions, and I'm supposed to be like trained in this, and I'm still really anxious. And I'm telling my wife, I'm not gonna volunteer anymore. This is like really stressful. At about the 4-week point, she did call me, and she's like, yeah, you know, it was my gallbladder, it was gallstones, they removed my gallbladder, I'm doing well, thanks for helping out. So, okay, that was a good story. So that turned out okay. But they don't always turn out okay. So, and I think you guys are making these types of decisions. Like, are we sending this guy on, and what are we gonna do? So I currently work for Workcare. We've been around for about 35 years. We do have a booth, so come by and say hello. I supervise like 15, we have like 15 salaried physicians and about another 15 contractors. It's a pretty big operation. So I've been doing that for a couple years. Injury management, I think I have some more stories I want to talk about. You guys, this is your bread and butter. I think you guys already deal with this. But I wanted to mention something that is sort of important to me because of current events, and that is Ukraine. How many of you guys have been to Ukraine, the country? At least 1, 2, a few more. So I had the good fortune of going there actually in 2012, about 10 years ago, and I visited a bunch of hospitals in Ukraine, including some of them which are current war zones. So I have sort of a connection there, and I've been thinking for the last few months, like they're a huge grain exporter and producer, and I think you guys probably have some, you know, brotherhood with them. And I was thinking, like, there's a lot of problems. Like, they probably need some safety and health infrastructure. There's probably things like unexplored ordinances. There's certainly a lack of personnel. Their trained people are probably either out of the country or at war. There's probably deferred maintenance. There's things that are probably rusting. There's probably equipment which no longer functions. There's supply chain issues. Like, in your own head, like, think, what would I do if I were in Ukraine for safety and health? And what if you need to send someone to the local hospital? Are there even physicians that are there? And then I thought to myself, in this meeting, you guys may have similar problems to a lesser scale. I know for at least physicians, there's a shortage, and there's a shortage of nurses. And you may think, oh, if we have a safety and health incident, we'll just call the local number. And then you end up calling, and they're like, oh, we close down at Fridays at noon, you know, for the local health clinic. You know, you may not have the same ambulance type services. You may not have the same equipment. You may not have the same infrastructure. You may not have the same trained workers. You may have workers who are partially trained or who are newly trained. And then you may have an aging workforce. You have guys who came back into the workforce to help out. So I think there's a lot of issues which you guys are ongoing, which make things more difficult. And again, the importance, you can read here some of the reasons which I think you guys already know about. And then there's I put this in. These are just a couple slides. I just want to congratulate all you guys for doing a great job. You see the numbers are definitely going down in crop production, and that's a nice little, I think that's purple, you know, going down, the line going down, and the numbers likewise reflect that the numbers are going down. You know, so this is from Health and Human Services. You know, it shows the going down from 7,500 or so in 2015 down to 5,500. That's a pretty nice decrease. I don't know what it's doing now. It might be going back up again. But that's good to know that you guys are doing well. There's some really good industry campaigns. I watched a video after I saw this on what exactly is an auger entanglement. It was not a pleasant video. It was like some fire guy showing how to like saw off and remove a guy's arm from an auger so it could be transported into the emergency room. Anybody ever have an auger entanglement issue? You guys seen that? Good, it's not that common. It looked pretty unpleasant. But these are the types of things you guys are dealing with, I'm assuming. And let me see if I have a couple notes here for myself to mention here. All right, I think we have these field management challenges. Again, I'm not going to go through these in detail. I think you guys are more aware of these. And then the solutions is the next slide. But as you guys are looking at these things, I really have, again, this is from my military experience of a way to really look at this. And again, this is my perspective. In addition to like if you look and observe and listen to people and ask pointed questions, you're going to come to the solution. The other thing is, as you're looking at these field management challenges, you can try to avoid a lot of these and get ahead of these through your site inspections and through really pushing policies and procedures and an emphasis on awareness. So what we usually did in the military is, if I were showing up for a safety site for some type of an inspection, I would go and talk directly with the physician who was working in there. And then I'd bring the senior enlisted guy who would sit down with all the corpsmen or the medics and would work with them and make sure all the policies are in place. And it was really a very non-confrontational, non-punitive, visit. And so we would really sit down and we would go through all of these things that they were talking about to really understand where they were coming from and to really reemphasize, the safety and health. Again, non-punitive in ways that are helpful. And we would try to see what's really working, what's not working. And so you see at the bottom here, access to 24/7 health care. I think almost everybody, I would assume, has that to some degree. Either a phone call, which is, very simple, sending text messages of photographs of injured parts or photographs of how the injury occurred to give a better idea. Or lastly, through video teleconferencing. The video teleconferencing could simply be a video teleconference where you're just sending a video of like the injury and what's going on, or it could be an official physician video teleconference. The only issue, particularly maybe with the middle states of the United States, with having a physician video teleconferencing is state licensing. So a lot of the physicians I work with have multiple state licenses. Very few of them have 50 state licenses. And so normally they have licenses for the most populous states. So, California, New York, some of these big states, a lot of physicians have licenses. In some of the smaller states, you don't have as many physicians. And you cannot do a video teleconference unless you're licensed in that state. So you probably have more limited availability and limited ability to talk to experts. Now, in 2020, in the beginning of COVID, the United States government changed a lot of licensing requirements. And because it was a COVID emergency, you could work across state licenses. I got a whole bunch of like temporary state licenses in different states, which were really easy to get because of COVID, where you could talk in between states. So the Mayo Clinic would be able to answer multiple calls. Mayo Clinic may actually have pretty good nationwide coverage. And I think the same thing with Harvard, Stanford University. Some of the larger medical centers probably have pretty good telemedicine services. But just be aware as you're looking at the telemedicine services to keep that in mind as you're moving forward. Because I think that is certainly an important thing to be thinking about. The other bullet points on here, the first aid kits. I'm hopeful that all of you guys have pretty good first aid kits. You're checking them regularly. In my military and government experience, it's not unusual where I would show up at a place and I would just say, hey, can you show me where your first aid kit is? And they would pull something out and they would open it, and a lot of the equipment was actually rusted, or the rubber tubing was broken, or things were expired. So again, when you do show up, just ask and just sort of take a look at what actually is functioning there. So those are some of the field management solutions. This is a slide where we often show, and I think this first aid versus medical treatment, I don't know if it's for this audience. I think this audience already knows this. OSHA is something which I spent a lot of time at OSHA when I was residency director for the military for occupational medicine. I spent a lot of time down at OSHA because it was in the DC area. And I'd go down and visit these guys. I knew these guys, they were my friends. There were like 6 physicians either in offices or cubicles, and they handled nationwide OSHA stuff. as MDs, as well as an enormous staff of other people in OSHA downtown. But as far as OSHA recordable stuff, if you guys have a doubling in your OSHA cases from one year to the next, how many of the people in this room would be called in to sort of like be part of a team to figure out what's going on? Like, just raise of hands. How many of you sort of work with OSHA recordable stuff? So that's a fair amount of people. And likewise, if the OSHA numbers go down, it's like, hey, congratulations, you're doing a nice job. There's usually a team award. A lot of the companies, they get like a team award, thanks for decreasing OSHA recordables. Great job. But I think this is pretty important. It may be pretty basic for you guys. I'll go through a couple of these things. This is what the physicians and nurses at my company, and in the military, we didn't worry so much about OSHA recordables, but certainly in the rest of the world, besides the military, this is a big deal. So first aid is essentially, there's a number of things in the legislation which talk about first aid, and then medical treatment is anything which is not first aid on the list. It's got to be on the list. So if you guys aren't already familiar with this, you can pull this out. Pretty much any website will go through this. I would ask who's not familiar with this. I'm thinking most of you probably are. And there's a second page here as well. Again, talking about these different things. And I used to go visit, because of the Pacific Submarine Force, and I also worked with divers nationwide and other units. And we all had, kits for first aid. And we all had kits for advanced first aid, including, other things, including surgical glue and these types of things, which are not officially on the first aid kit, but sometimes can be very useful. So, advanced first aid kit. I'm going to take an opportunity here just to read something when you're talking about first aid and when you're talking about when do you call 911 and when do you do something in between. You don't call 911 and it's not really just all first aid, but you want to call like a triage line and get more information. But according to the American College of Emergency Physicians, this is the recommendation for calling 911. So there's 4 questions that should help you call 911. They're not completely specific, obviously. The first one is the condition life-threatening? Second one is, could the condition rapidly worsen on the way to the hospital without emergency transport? The third is, if the victim is moved by non-medical professionals, is it likely to increase health risk or cause further injury? And lastly, do injured or ill people need the skills and equipment provided by paramedics or EMTs? And if any of those questions are a yes, then you should just call 911. Do not bother to call a triage line. Do not bother to call anyone else. Just call 911. Those aren't always easy. When I was at the Pacific Submarine Force, I actually credentialed physicians all over the Pacific, including in San Diego. And again, I'll relay another medical story. I hope these medical stories are helpful. I figure I'm the only MD here, so I figure I can tell medical stories. Maybe they'll jog things in your own memory to think about cases that you've seen. This is about maybe 20 years ago, and they had these new immune agents for people with rheumatoid arthritis. I think Phil Mickelson, the golfer, may have been promoting some of these oral agents, these pills you can take if you have rheumatoid arthritis. They sort of alter your immune system a little bit. The FDA had recently approved them. They weren't really fully understood the effect they would have on an immune system. So the physician who worked for me in San Diego was out of town on vacation, and his office, nurses and corpsmen were working there, and this guy came into the clinic, and he wasn't feeling well, like he had the flu, maybe something going on, upper respiratory infection, and they evaluated him, and they called another physician who was covering in another site, and they talked to him on the phone, and they're like, yeah, I have this guy, he's on this new medication for arthritis, but he's doing okay. He seems a little short of breath, but he's not that short of breath. And his lungs sound more or less clear. It's sort of hard to hear him. And we asked him if he wanted to go to the emergency room by an ambulance, and he's like, no, I don't think I need an ambulance. You guys can just drive me. So there were a couple other complicating issues with this story, but the bottom line is they had somebody drive him up to the hospital. On the way to the hospital, it was about a 12-minute drive. They're driving up to the hospital, and the guy loses consciousness. And his lungs had filled with fluid. And he actually was hospitalized and almost died. And they asked me to review all this case, and I'm reading through it, and I'm like, gosh, And then, of course, you read later, there are some case reports that this new medication alters the immune system, and if you have a mild flu, it can actually progress very rapidly because your immune system is not reacting appropriately, and your lungs can fill with fluid. So it became like 5 years later, maybe, it was like a black box warning, like you got to be careful with this. But at the time, it really wasn't known. So even with the best of intentions, deciding when to have an emergency transit and when not to. So not only was it, by the way, bad for the guy with the pneumonia, but it was pretty traumatic for this young man who was asked to drive him, and while he's driving, the guy loses consciousness and almost dies. I mean, that's sort of traumatic for both ways. And of course, it sparked an investigation, and the Naval Hospital asked me to review it because they were credentialed under my license. So anyways, this is the complexities you often have to deal with. Well, you not personally, but in a way you probably do, depending if you can get a hold of a physician or a nurse or a triage. These are the types of decisions you guys are making. All right, so advanced first aid kits. Most of you probably, all of you guys should have first aid kits already. Take a look, see what you have. Ask the guys who are actually on location, what do you think we might need? You know, what have you had a near miss? You know, what do you think you might need later that could be helpful? This is a slide which, again, was in a previous presentation. You know, they had mentioned if you do have over-the-counter medications, don't have the manager give the guy a number of pills. Just the manager can say, this is an over-the-counter medication. If you feel like this might be helpful for you, you can hand him the bottle and he can take a couple pills himself, but you don't want to actually dispense it. Okay, I have a bunch of things here. There's these ACOM guidelines, by the way, are like 300 pages. So it's not like you can just go and read these simply. But back pain is very common. As a neurologist, I'll tell you that if the red flags, okay, radiating pain, weakness down the leg, bad sign, okay, loss of bowel or bladder control, that's like an emergent sign. Like if somebody has low back pain and they can't feel their bowel or their bladder, then they got to go to the emergency room immediately. That's probably Cauda-Equina syndrome, which is a bad thing. A lot of times, though, we all have back pain. I wake up sometimes with back pain. I'm at the gym. I was on a submarine exercising with a bunch of my colleagues, and I did something to my back. And I was on board for a while, and I just sort of self-treated. Didn't even tell anybody, right? You know, back pain. But just keep that in mind. I'm sure you're seeing a lot of that. Knees. Again, the only real advice I have, the only real thing to really consider is a big one, is instability. If somebody's telling you he's walking and he goes on an uneven surface and his knee sort of gives out, that's a concern because there's probably some significant ligamental laxity or damage, and if it gives out again, it can cause injury to the remaining tendons and other structures. So if that knee gives way, that's something to really push that guy to get something evaluated. Elbows. This is almost all overuse injury. This is like tennis elbow, golf elbow. These things happen a lot. My relatives call me frequently with these types of issues. Actually, my relatives call me all the time about all kinds of issues. And it's always, it's always reassurance. And occasionally I say, you got to go to the emergency room. But that's very rare. 90% of the time it's reassurance. In fact, I'm going to take, how are we doing on time here? Oh, good, we're plenty of time. One of the things that really works best, if you're like at a work site and you're like a manager or a supervisor there, if somebody has an injury, any of these musculoskeletal things, anything else, just, if the guy says, hey, if he downplays it, he doesn't want to do very much about it, just say, hey, that's okay. But, every morning before you start your shift, for the next few days, just stop by and let me just one-on-one, let me just see how you're doing. Your shoulder hurts, just let me see, how's it doing today? Lift it up for me, show me. And just pay attention. And just, again, it's not punitive, you're not trying to have him lose his job, it's just, you just sort of have him just as a routine, like any small injury, have them come by. Because other than that, somebody's going to injure their shoulder. I've seen this happen hundreds of times. They injure their shoulder, they say, I'm okay. And then if you ask them, like, well, can you lift it over your head? They're like, I can only lift it this far. And you're like, well, is that normal for you? Not really. Because they'll tell you, oh, my shoulder hurts, but it hurts all the time. This is normal. But when you actually ask them to do something and you observe what they're doing, it's not. And the problem is if you don't ask them, then it'll linger for a few days. If you ask them every morning, eventually they'll say to you, well, yeah, maybe I should not do this type of work, or maybe I should ask a physician to take a look at it. Otherwise, they're going to be climbing up ladders like one hand, and then they sort of like brace themselves with their back shoulder and one arm, and they'll find modifications. Human beings are smart. They'll be able to do their job in a modified way, but it's not always a safe way. And then they're going to fall off a ladder, and you're going to say, what happened? And you're going to know, well, a week ago when I hurt my shoulder, I haven't been able to climb ladders normally, so I've been modified, and that's why I fell off the ladder. So again, just ask people to check in with you routinely, and we did this in the military all the time. So again, I worked in very high-risk areas of the military. I ended up working, again, with nuclear submarines, special forces divers, experimental diving, and so we had physicians who were specifically assigned. I think in my introduction you said I was a flight surgeon, but I was actually undersea medicine, not flight surgeon. But the flight surgeons and the undersea medicine are specific things in the U.S. Navy, specific to high-risk occupations. And then you have corpsmen and medics who are embedded with the units. They exercise with them, they work with them every day, they're trusted by them. And so if there's somebody on site, whether it's a nurse or whether it's someone in a health clinic or a wellness clinic or a physical therapist, or even just a manager with some ability to sort of do some supervision, just keeping close tabs with people is really, really valuable in preventing injuries and increasing safety. Most people don't have this because it's expensive. I mean, it's a cost to have these extra personnel. The places I worked in the military, it's ridiculous talking about it because I had unlimited funding, frankly. For nuclear submarines and special forces and diving, we had like unlimited money because it's such a high risk. You never want to have an injury or an accident. So, for most real people in the real world, you don't have that luxury, but whatever you can incorporate, I think as a physician would be my recommendation. All right, so those are elbows. Hands. Now, so during my I did an internal medicine internship, when I first, started my postgraduate training, and I had to do 1 month of orthopedics. And I was really excited to do something on knees and elbows and shoulders and hips and big joints, right? And instead, I got stuck with a hand surgeon for an entire month. But there's a few things I learned from the hand surgeon. Number one, if you have a laceration, you see these tendons that are running through these sleeves that help your fingers move. The hand is a super cool thing. But sometimes you're working with something, you have a knife in your hand, and it slips, and you sort of lacerate one of your fingers right there. And you go into the emergency room or something, and he's like, well, can you still flex that finger? And it's like, yeah, I can still flex it. It's fine. No, it's not fine. Then I'll watch as the doctor looks at this opening here and finds the tendon, and then has the guy move his finger, and you see the tendon there underneath, not where you can visualize it, but you can visualize it as he's moving it, and underneath it's 3/4 of the way sliced. There's only 1/4 left. And if this guy doesn't go to a hand surgeon and have that repaired, then during his rehabilitation 2 weeks from now, it's just going to snap completely. So anything with a hand like that, have him be seen by a hand surgeon. And I've seen this in the emergency room often as well, where the emergency room physician will say, I'm going to talk to the guy, but he needs to get this irrigated and evaluated by a hand surgeon. We don't mess with people's hands. They're too valuable. The other big thing is infections. So you'll see in the photo, or in the diagram here, these sleeves where the tendons run through. So if that gets infected, that infectious pus is just going to run up and down that sleeve. And if you give the guy antibiotics, they have a hard time getting into that sleeve because there's just not good blood. There's not blood flow through there. It's a sleeve. And so the infection will go through the entire hand, cause major problems. You really don't want to have a hand infection. So again, hands, lacerations of the hands, really make sure this guy goes to the emergency room. And if you don't think it's a really good emergency room or a really good local physician and clinic, push to send him a few hours to see a hand specialist early on, because hands are pretty valuable things. You never want to have a hand injury. So that's the story on hands. Ankles and feet, these things are injured a lot as well. I almost have some, I'm sure there's horror stories out there. There's a lot of people who they have to fuse the ankle and they're walking around for the rest of their lives limping. I have other stories of people who've had pretty good surgeons. They've put in some plates and screws, and 30 years later, after fracturing their ankle, they're still running every day for 3 miles a day. And so ankles are usually pretty durable, but again, repeated injuries of the ankle are going to cause problems. And Not a lot of red flags there, but again, pay attention to them because people get ankle sprains, they ignore them. All right, these next few slides are from a previous presentation on rashes. Not super exciting to me. You guys probably know about rashes. The really thing I would really encourage you is take photos, not only to send to somebody, but to look at over time. Take a photo, anything like this you can take a photograph of, and then see what's going on like the next day, or 12 hours later. Monkeypox is a big thing. It looks like smallpox. Vesicles, contagious. Monkeypox is, I guess, now a World Health Organization, problem. The U.S. has a lot of cases. So anything, like a rash, make sure you consider taking photographs. Get in some good lighting, by the way, and just, it's always a good idea. First aid, again, I don't think I'm going to talk a lot about first aid, but again, from a prior presentation, this can also be guided by somebody on the phone. They can help give guidance for that. Otherwise, it's going to keep people out of work. Poisonous plants, we've all had poison ivy before. Again, this is more of a preventive thing as well. When you go to a site visit, when you're looking around your plant, looking around your location, take care of poison ivy. There's where I live in Carmel, there's a Frisbee golf place they just set up. I'm like, oh great, there's a Frisbee golf. And so it's out in the woods underneath the oak trees, and it's this brand new course. And I went out there, and there's this poison ivy everywhere. And there's a little sign that says, be aware of poison ivy. But so what? There's poison ivy everywhere. This is ridiculous. So I have not gone back. I'm waiting for them to clean out the poison ivy. That's completely preventative. First aid, the beauty now is that compared to 20 years ago when I'd be talking to audiences, you can almost look online and get an immediate Google search on treating this stuff. Keep in mind, though, for anything which you're going to give the guy, like an antihistamine, make sure it's over the counter. It's going to be non-drowsy. I mean, that's really a problem if you tell a guy, oh, just take an antihistamine, that'll cause some of the itching. And there's something like Benadryl, which makes you drowsy. Benadryl is a great sedative in a way. It helps you get to sleep at night. Take a Benadryl at night. It's actually used as a sleeping aid for a lot of my neurology patients who have other cognitive issues. I can use Benadryl as sort of a relatively mild thing to enhance you to get to sleep easier. But you should not be taking Benadryl when you're getting ready to work. All right, heat rash. I'm not going to talk a lot about this. I think I have some here. Heat stroke is coming up, heat illness. Insect bites, again, I don't think I need to cover insect bites today very much. Bites and stings. Oh, tetanus is on the bottom of the slide. I kept the slide because it mentions tetanus. Do pay attention to tetanus. Any puncture wounds, not so much for insect bites, but certainly puncture wounds, nail through the foot, those types of things. Make sure you're up to date on tetanus. Otherwise, it's a very painful illness to have if you are not protecting yourself against tetanus. And make sure every 10 years you have a tetanus booster. All right, this is from OSHA. It was cut off from the bottom of the slide. I'm not going to give you guys a lot of brilliant things on heat illness. I'm just going to tell you, you guys all know about heat. Everyone in this room has had probably a mild heat illness at some point in your lives, if not multiple points in your life. This is a really great OSHA handout. It's a little bit larger. Again, at the bottom it says OSHA. Print these out, distribute these, put these front and center when you're walking around talking to people, the managers, the frontline people, everyone else. Remind them about heat illness. And even more so, do a tabletop exercise or do an actual site inspection. When you're asking the guy, hey, if Jim over there is suffering from heat illness, what are you going to do? And they're going to say, oh, we'll get some ice. Well, did you have ice here? No, but we can have someone go drive a truck and we can get some ice here at some point. Are you going to, are there other things that you can do? And do you have shade here? It's well, it depends on the time of day. So actually ask them, if you had a heat illness today, how are you guys going to manage this? And do you have plans that really actual plans in place? Because people think that they do, but of course, when you actually ask them what they actually have, they might not. So really sort of take this very seriously. And there's a lot of other things you can do. There's a lot of resources on this that you guys are probably at least as aware of than I. If you guys are safety professionals, you guys already know this. I have a trivia question for you guys. What's the driest continent on the planet? Antarctica, yeah, that's right. And arguably, the dry valleys near McMurdo Station in Antarctica is like the driest place in the world. And I did have the good fortune of going there, gosh, maybe in 2013 or 14, to do a study for them and for the National Science Foundation. And I arrived there, and I knew it was the driest place on Earth. And I was in this little visitors, building. It was almost like a modular unit. And I took a shower, and then I went back to the room, and then I was coming back through the area where the kitchen is and the shower, and I looked inside, and it was like 10 minutes later, and my towel was already dry, and there was no moisture at all on the walls of the shower. Like, you could go on the walls of the shower, and everything was completely dry, 10 minutes. That's how dry it was. And so what did they do? So there's a lot of things that they did. Number one is they did have, in every men's urinal, they had like an 8x10 piece of paper on it, and it had like a little cartoon figure of a man urinating, like a little cartoon of a guy in front of a urinal. And then they had different shades of yellow going down. Like they had like white, light yellow, yellow, dark yellow, yellow, orange. And they said, if you're looking down at your urine stream, and if it's not like white or light yellow, you're dehydrated. So drink more fluid. So, simple things, like that make a difference. The other thing they did, which I thought was, this is one of these comical things of human nature. I was the chair of their polar programs for National Science Foundation, their medical panel. So we met every year and we talked about things that had gone on during that year. It was contracted out, I think most recently, it was through Raytheon, and then it was through University of Southern Texas maybe, to provide some health care for there. But they would go through all these alcohol-related incidents. And when I went down there to visit, I began to understand that alcohol is like a big part of the culture if you want to go down to Antarctica. There was like a lot of drinking in McMurdo. And they had a big sign on the front door of like the market, or the place where you buy food and knickknacks and alcohol. And they had a sign in the very beginning, and it says, new policy. Maximum alcohol that you can buy per day is like 2 6-packs of beer, 2 bottles of wine, or 1 bottle of hard liquor. And it was like really strict, like it's like you can't buy all 3. And I'm like, that's still an enormous amount of alcohol. And there were also 2 bars at McMurdo where you could drink. So anyways, alcohol is obviously also dehydrating. So, even though we talk about dehydration and heat illness, there's probably a lot of things built into our culture which make things a little worse. But just be aware of those. You probably can't change the human nature. I'm also going to point out, as a neurologist, that all of these things are neurologic. So when you think about heat illness and you're talking to somebody, that top section right there, all of the medical emergency. So it's all your brain, right? It's abnormal thinking or behavior, slurred speech, seizures, loss of consciousness. All bad things, all with your brain. So your brain, by the way, just to remind you, is encased in this skull, and it's really protective. Like any fluctuations in blood pressure, any fluctuations in metabolites, any fluctuations in temperature, your brain is encased in a skull to protect it. So you have, if it's really cold, you have huge amounts of blood vessels outside of your skull. If you've ever seen somebody with a head injury, a very mild head laceration, it bleeds like crazy because you have a lot of blood flowing through to keep your skull warm when it's cold. And likewise, you have a lot of sweating and a lot of mechanisms when you're really hot. But as soon as that brain is overcome with heat is when you're going to see symptoms. So think about heat injury, think about brain, and think about what the person's behavior is. I got one more time, maybe a little time for another vignette. So when I was a Navy diver, they would train us that when you get out of the water after every dive, you have to go up to your master. You get out of the water, you go up to the master diver, you have to look him in the eye, and you have to say, diver on deck, diver okay, and you have to give like an okay signal. So essentially, the master diver is going to stare at you, and he is going to look at your eyes, and he's going to look at your behavior. He's going to make sure you got the words correct, and he's going to make sure, in addition to while you're speaking the words, you put your hand up. So he's really looking at your neurologic stability as you're coming out of the water to make sure you don't have decompression sickness or an arterial gas embolism. And it's a very careful observation. And so I would encourage you to let your guys know when you're talking about heat illness, it's very careful observation. Because if a guy's having early symptoms of heat illness, but he really needs the money or he really needs the job, he's going to say he's fine. And he's going to say he's fine while he's avoiding eye contact. And he's going to say he's fine while he's sort of like keeping a distance so that you don't see that he's having early symptoms. So a lot of this is just observation and listening. You know, have that supervisor walk up to a guy and just go like 3 feet away and say, how you doing? You know, look me in the eye, how are you doing? I mean, that's really where this is going to, and that sounds silly, but that's why the military diving community has that in place, because they know human nature is to avoid, you know, showing any signs of weakness and to sort of like help hide any signs of early illness. So that's again a recommendation that I have for you that I think is a practical, very practical way of looking out for heat illness. And if guys know that they're being watched and that people are looking out for early heat illness, then they're going to take better care of themselves. They're going to be drinking more. In fact, you're not going to find it because they're going to be drinking more water because they know their supervisor's going to come up and look them in the eye and say, how are you feeling? So in a way, by instituting these types of policies, you're going to change behavior without even asking them to change their behavior. All right, telehealth applications. I talked a little bit about this already. Again, nowadays we have smartphones. I thought I increased the lines on here a little bit, but it looks super tiny. I don't think you guys can even read it. I can't even read it on this. I have like a little cheat screen in front of me here. I'm having a hard time reading it even there. So anyways, I think most of you probably have the potential, at least for a smartphone telephone visit. Remote video assist is a lot of guys are doing this now for video visits. In the next 5 years, this will be even more common on your phones. And again, it's just a matter of trying to keep the state licensure boards and the administrative burden of having, you know, more physician contact. You know, as you know, healthcare is severely regulated in this country in multiple ways, and it makes it actually difficult for those of you who are on the, you know, who are actually on the ground doing the real work. So, again, I appreciate all you guys are doing. Yeah, sharing protected information with another provider. All right, these are some of the applications. Again, a lot of you guys are probably already using field triage, referral decisions, follow-up visits. If you initially see someone in the clinic, it's not a bad idea to have somebody call ahead and to say, look, you know, if this guy can still come back to work, we have ways that we can allow him to come back to work even after his injury. Try to prevent a brick and mortar that makes money off of like doing unnecessary procedures and physical therapy and other types of things. You know, if a physician or someone else, or if someone else can call ahead and say, we have this guy coming in, then sometimes that can sort of change behaviors. But I know this is tricky for you guys. In the real world, sometimes you send a guy to a clinic and they end up getting more problems from that. All right. This is my last slide, I think, and I put it in here. And I put this in when I was, again, thinking about what I did in the military, in remote environments, you know, whether you're in Antarctica or whether you're in Ukraine or whether you're in Peru. You know, I've been to a lot of places, and really the safety and health really came from just people showing up and saying, show me what you do. You know, just observe what they're doing, ask them questions. You know, just, you know, people like talking about their work, like they show pride in it. If you ask somebody what they're doing on this machinery, he'll spend like 20 minutes explaining, you know, how the machinery works and the pride he has in maintaining and using this machine. So when you show up at a site and you're talking to people in different divisions, different departments, different, you know, sites, different, you know, places you have throughout your business, you know, people usually are very proud of what they have. And if you ask them to, you know, break out the medical equipment, you know, show me with the number you call if you have an injury. You know, show me the number you call if that place is closed. You know, if it's only open 9 to 5, then they close down. Or if the doctor's on vacation for a week. You know, I mean, show me how you do these things. And I think lots of times you can really get a lot of benefit from that. And I think that's about it. And then I have questions, and I think I have 10 minutes or so for questions.
Yes, you do. Thank you, Dr. Jankosky. Do we have questions for Dr. Jankosky? Jess?
Wow, this is a really quiet group.
Yeah, well, I just had a question for you. So what about light duty or temporary restrictions, right? So I think that's something a lot of these facilities will have to deal with. You can have an employee that's injured and they come back and, you know, according to the doctor, they have some of that. So what would you recommend to alleviate a concern if an employee wants to do what their previous job was? So how would you handle that?
Personally, and in my occupational medicine training, and again, I've been very fortunate to have training at really these sort of like, in some ways they're like ivory tower institutions, like places like Johns Hopkins, National Institutes of Health, Georgetown is where I did most of my training, and you'd think that they would be, sort of risk averse, but everybody teaches the same thing, is to get worker back to work. Get the employee back with his fellow employees, having him feel useful, having him feel like he's moving forward, having him feel like he's recovering. And you see this at the ground level as well, where having an employee out of work for long blocks of time, studies have shown doesn't really help. Having him back to work, even if there's some type of a limitation, even if there's some type of an accommodation, if there's some way to get a patient back to work quicker, that's really the best way to go. If you keep somebody out of work for a long period of time, there's more injuries later, there's more problems later, there's more disruption in the workplace, there's more disruption for the worker's individual life. I'll give you an example, which I don't, again, share a lot, but I think it's a good example. There was a submarine collision with an undersea mountain. I wrote a paper on this, so it's public knowledge. I was in charge of the Pacific Submarine Force at the time. The USS San Francisco collided with the undersea mountain as it was traversing between its home base in Guam down to Australia. And about 80% of the crew was injured. They didn't have I won't go into the details. Anyways, and there was one fatality. There was another guy who had a pretty serious head injury and who lost consciousness and had some brain contusions. And according to the rules of the U.S. Navy, he was a nuclear submarine operator. He had to be disqualified from any nuclear work, and he would have to be put into the, sort of like injured reserve area where he doesn't get to do a job. He just sort of sits at a desk and does nothing, like answers a phone, for months, and then probably kicked out of the Navy. And I talked to him and his wife. I flew out to Guam. I talked to most of the guys on the crew. And everybody liked this guy, and he was a really good worker. But, he had this serious head injury, and his wife said his personality had changed a little bit. Again, this is getting back to the limited duty story. So I talked to him, and his wife says personality, he's a little more irritable. But, the commanding officer, the executive officer, his senior management all liked him, and he said he can still do his job. And by the way, because we have to cut the ship in half and replace it with a new front part, because the back part was just refueled with nuclear fuel. We're not going to get rid of it, the submarine. We're not going to have an operating nuclear reactor for the next 2 years while we're in shipyard. And so I told the guy he could stay on board and stay as a nuclear reactor operator, but not on a functioning nuclear reactor that was operational. And so I was able to get around it. So he stayed on board. Otherwise, him and his wife would have been stuck in Guam because the boat was actually going to go to the shipyard in Washington State. So he would have stayed behind in Guam and got kicked out of the Navy. And as like a 24-year-old kid with nuclear operator experience, kicked out of the Navy, that's not good for him. So I did formal neuropsych testing with him, sent him out to Triple Army Hospital in Hawaii, let him go back to the shipyard to work on the boat with the non-functioning nuclear reactor, and after about 18 months, had him reevaluated and let him go back to continue his job. So it was essentially 2 years or like 18 months of limited duty, and it's what he wanted as well. I mean, he didn't really have, him and his wife didn't have, and his child, I think it would be really difficult if I would have just followed the rules and just kicked him out. So again, that's sort of an extreme example of keeping a guy in his occupation rather than allowing him to just sort of like be kicked out of the military. And again, I think he would have had a difficult time finding a job otherwise. So again, and also he got he was with his friends every day. He had his comrades. He liked everybody who worked with him. Anyways, a longer, more complex story is behind this, but it worked out really, really well. So I think keeping people at work under limited circumstances is always the best way to go. Sorry, really a long answer there.
Any other questions? Thank you, Dr.
All right,
Janowski.
well, thank you guys very much. Have a great afternoon.